Okay, today we're going to walk through some temporal bone anatomy on a non-contrasted CT of the temporal bone. We'll start from external ear on this module and go all the way to the oval window. And the next module we'll pick it up from the oval window and go down to the brainstem. So just a little bit of anatomy of the external ear. This is generally going to be considered surface anatomy. I don't think the radiologist plays a huge role in this. There are cases in which you're going to look at infections and tumors of the external auditory canal, but certainly the external ear is fairly evident to your clinicians. But there is some anatomy that you can appreciate. So generally called the auricle, but the helix is considered the posterior portion here. And as we scroll a little bit more here, this is considered the tragus of the external ear. So you could give the otologist a measurement. If you see an EAC or external auditory canal lesion, you could give them centimeters from the tragus. That would maybe help them clinically, but again, external ears generally surface. Here's the external auditory canal. This is embryologically derived from the first branchial cleft. And it takes sort of a S-shaped curve, as you can sort of see here. As you enter the orifice of the external auditory canal, it takes a slight anterior course, and then you can see it dive slightly posteriorly as it comes in, maybe again a very gentle anterior turn before it hits the tympanic membrane, and we'll get to that in just a second. But you can appreciate a couple different densities that make up the wall of the canal. This is the cartilaginous portion of the external auditory canal. You can see that both anteriorly and posteriorly. And here comes the bony portion of the external auditory canal. You can see that both anteriorly and posteriorly. As you can see, that the anterior wall of the EAC is the posterior wall of the temporomandibular joint, essentially, and the posterior wall of the EAC is shared by the mastoid air cells posteriorly. Now, there is a relative narrowing here. This is one of the isthmus of the external auditory canal. You know, if there's a foreign object that's in the EAC, it's generally much more difficult to get out once it makes it past this isthmus. So, you know, you hear kids putting marbles in their ears and that type of thing. It's a lot more difficult to get out if it makes it past this little isthmus here. So the other thing I really want you to see here is this little wisp, and that is your tympanic membrane. This is probably as thick as you should see a normal tympanic membrane. I'm going to bring you over here to the coronal images, and again, it's a tiny little wisp. Anything more obvious than that little wisp is probably a little TM thickening for whatever reason, but you shouldn't see it more than a tiny little wisp there, and you can sort of appreciate it probably best on that image there. Now we're going to make our way into the middle ear cavity, and we're going to sort of compartmentalize this to make it the terminology a little bit more clear. This bony structure here on the coronal image is called the scutum, and this is where the superior attachment of the tympanic membrane is going to be. That attaches inferiorly here by the tympanic annulus inferiorly. So the TM is going to stretch from essentially this point of the scutum all the way down here to the tympanic annulus. Now, if we draw horizontal lines from the scutum to the middle ear cavity that way, and another horizontal line from that inferior annulus across that way, that's going to compartmentalize our middle ear cavity in a couple ways. So superior to that line, again, I'll draw that line again. Superior to this line is going to be considered the epitympanum. In between these two lines is the mesotympanum, and just inferiorly to this line, there's not a lot of space on this cut, but there is some space there for the hypotympanum. And we're going to show these spaces on the axial images too and correlate with what we see here. So as we come to the axial images here, I'm going to scroll all the way up to the epitympanum, and we're going to really sort of look at the middle ear ossicles in this space here. Some good anatomy to point out here, and I'm going to blow this up a little bit. So in the epitympanum, we have the malleolar head and the short process of the incus. You can see that. And this is often referred to as the ice cream cone configuration. You know you're in the epitympanum when you have an ice cream cone configuration of the ossicle. So again, this is the head of the malleus, and this is the short process of the incus. And this is sort of sitting in what they call the tail. The short process in the fossa incutus here. Another sort of interesting piece of anatomy here is this tiny septation that you see in the epitympanum. This is called the epitympanic cog. A little bit more anatomy in the epitympanic space here. You can sort of see as I get even more superior, the epitympanum communicates with the mastoid air cells back here, and this conduit that you see here is the adductus ad antrum. So that's how the middle ear cavity communicates with the mastoid air cells, is through the addutus ad antrum there. Remember, I'm as far superior as I can be here. And in fact, now that I've laid a reference line down, you can appreciate the fact that I'm this far high up in the epitympanic space. You can see that it's all air there, and this is going to be the communication between the middle ear cavity and the mastoid air cells. Remember, again, this is the addutus ad antrum. As I come down, I start seeing the ossicles, and there's my epitympanic configuration of the middle ear ossicles with the malleolar head and the short process of the incus. Now, as I make my way down to the mesotympanum, I start seeing a two-dot configuration here. Now, a little side note, the malleus, that's considered the hammer. So you have a head, you have a neck, and you essentially have a handle. And this would be, just inferior to the head. You obviously have the neck, and as we come down, you see the handle of the malleus, or the manubrium of the malleus. The incus here has a short process. It has a body here, as you can see as I scroll down. And finally, what you start getting is a long process of the incus. So once you see this two-dot configuration, we're making our way to the mesotympanum. As you can see, we're very close to the inferior margin of the bony scutum, and we're making our way to the mesotympanum. So if you see a two-dot configuration, again, this is the manubrium of the malleus, or the handle of the malleus, and the long process of the incus posteriorly, we're in the mesotympanum. I want you to follow the malleus a little bit, and this is where the malleus, the manubrium of the malleus, makes its contact with the tympanic membrane. If you look on the otoscopic examination, you often see that point at which the malleus is going to sort of abut the tympanic membrane on your otoscopic exam, and that's that point right there. So coming back up, we see that. Now, if we follow the long process of the incus down, it essentially takes a little bit of a turn at its very tip, and this is called the lentiform process. We start seeing the stapes footplate superstructure come in here. And we see that articulation between the long process of the incus and the head of the stapes here. So once that articulates, we get an appreciation for the stapes superstructure. And if I zoom up just a little bit on this image, you can see the anterior and posterior crura just make them out of the stapes. This would be the anterior crura, the posterior crura, and this is the stapes footplate, and this is going to abut the oval window, which sits adjacent to the vestibule, which we'll get into in a little bit. But that is the oval window there. So let's backtrack a little bit, and I want you to imagine the transmission of sound coming through the structures that we just mentioned. So sound here is going to be directed towards the external auditory canal by the structures of your external ear. Once sound is directed from the external auditory canal, it is essentially funneled down to the tympanic membrane, which we see here. Remember that tympanic membrane is also a sort of a conical structure, so it absorbs all that sound energy and it tries to harvest it on a point, and that point is where that sound wave is going to turn to vibration of the tympanic membrane. The vibration of the tympanic membrane sets off a vibration of your middle ear ossicles. First, this malleus is going to start to vibrate. That articulation, this is the malleoincutal articulation here. The malleus starts to vibrate the incus. The incus will come down, and through the lentiform articulation, or the incutostapedial articulation here, it starts to vibrate the stapes. The stapes footplate shakes, and that starts to vibrate the oval window. The oval window will start a fluid wave here in the vestibule, and ultimately the cochlea where sound will be registered. Now, in the same light, you have this tiny little secondary, what we call a secondary tympanic membrane here, and this is the round window. So every time the oval window pushes in, the round window has to push out for there to be proper pressure differences to appreciate sound. So that's what a sound wave is going to do. Again, coming in EAC, vibrate tympanic membrane. vibrate the middle ear ossicles, essentially making its way down to the stapes foot plate and causing a fluid wave in your oval window. This is essentially how you should be dictating these studies. Up until the oval window, this is what a conductive hearing loss is going to involve. So anything that inhibits that process along any steps that we just talked about, whether you have external auditory canal abnormalities, whether you have tympanic membrane abnormalities, whether you have ossicular abnormalities, oval window atresias, otosclerosis, those types of things, all those things are going to cause a conductive hearing loss in a patient. The other little piece of anatomy I want to point out here, remember we're in the epitympanum because you see that ice cream configuration is this septum right here. It's a little bit of a prominent septum. This is called Kerner's septum. Just a little piece of anatomy you should keep in mind. A couple other things I want you to note about the middle ear ossicles. Oftentimes we, in the setting of trauma, we may have dislocation of middle ear ossicles. And if you know the anatomy, you know which one of these ossicles is most likely to dislocate. So if you look at the fixed points of these ossicles, you can see that the handle of the malleus, again, is somewhat fixed to the tympanic membrane. Now, if I go up to the malleolar head, there's a few attachment points that you can see. Well, most you can't, but one you can. So there is an anterior process that has a ligament that attaches this way. There is a lateral process that may have a ligament. There's also an apical process that you can't really appreciate even on the the coronal imaging. You won't be able to appreciate the apical process, but there is one attachment that you can appreciate, and that makes us bring out a new piece of anatomy here. And as I scroll, you can see this soft tissue density coming into the middle ear. This is the tensor tympani muscle, as you can see as I'm scrolling here. The tensor tympani muscle has a ligament that essentially attaches to the malleolar neck. And that's going to be the medial attachment. You see that little process that's coming out here? That's going to send out a ligament, essentially right there, to attach to the malleolar neck. So it may even be that little wisp right there. So, you know, an interesting sort of trivia question is there's only two muscles that make their way through the middle ear. One of them being tensor tympani, which you see coming in from the anterior direction this way. And again, the medial attachment of the malleolar head is the tendon of the tensor tympani muscle, which brings the question of another piece of anatomy in the posterior space of the middle ear cavity. What is the second muscle that comes in? The second muscle that's going to come in is the stapedius muscle, and that's going to attach to the stapes. You probably get a sense of that here. A couple other pieces here. So this, in the posterior tympanic space, you have this triangular thing here. This is the pyramidal eminence. This is the facial recess, and this is what we call sinus tympani here. So a couple pieces of important anatomy here. The pyramidal eminence houses the stapedius muscle. There's a tiny perforation at its apex where it will send its ligament to attach to the stapes superstructure, which you sort of see right there. The clinical significance behind sinus tympani is when an otologist comes in to remove cholesteatoma. Oftentimes this is a relative blind spot to the otologist, and it's an important thing to mention that you see soft tissue density that's occupying sinus tympani, so he may be able to take his scope and turn that corner and get all of that cholesteatoma out. The facial recess here, also a very important structure. Oftentimes surgeries for middle ear pathology, they want to come through the facial recess in that way. So seeing how wide or accessible the facial recess is somewhat important. So just a couple other little small anatomy pieces there. So that really covers what we're going to cover up until the oval window, and the next video will be from the oval window, and we'll talk about the inner ear structures. We'll address the facial nerve course in the next series, and some other of the anatomy that's pertinent to the inner ear.